So these are the projected numbers of cancers in the United States for this year. And as you can see, those are quite a lot. About 800,000 women in total will be diagnosed of cancer this year, and almost 300,000 women will die. These are the most frequent cancers, and these are the cancers I'd like to talk about. And you can see that breast cancer, of course, is by far the most frequent, but because of the screening, lots of cancers are diagnosed very early. You can see the survival rate is quite good. Only a comparatively small number of patients die from breast cancer. On the other hand, you see lung cancer oftentimes is diagnosed late, and you see the death rate is also much higher. So why do women get cancer? Why do people get cancer? Well, I always say if I could give you a good answer, I would be ready for the Nobel Prize. But I am not. There are so many different reasons, and the development of cancer is usually not one thing going wrong. It's several things going wrong. Even with the inherited cancers, you know, there is one step where a cell is a little bit abnormal, another step where it's a little bit more abnormal, a third step where it learns how to grow into other tissue, the fourth step where it learns how to spread and settle down to other tissues. And usually this development takes quite a while, sometimes even many years, like for instance cervix cancers. So in general, risk factors for cancer are, let's start with the environmental risk factors. Infections are very important for women here in the United States. Of course, the human papillomavirus infection, which is related to cervical cancer, but also the hepatitis virus infection, which is related to liver cancer. So there are a variety of others. Lifestyle is very important. We all know about smoking and the increased risk of lung cancer. Another factor is obesity, which is really starting to turn out to be a more and more important factor for the development of many cancers, such as uterine cancers, a little bit of breast cancer too, and also for the overall survival from cancer. So obese patients have a harder time to cope with cancer. And of course, dietary factor, if we look at colon cancer, you know, red meat and a lot of other factors. Occupational risk factors overall are rarer now because we pay closer attention. The main example here is the asbestos, which can cause mesothelioma, can cause a lot of cancers. Hereditary cancer is a very high risk factor, but it usually affects only about 8 to 10% of patients with cancer. So this is something always to keep in the back of your mind, although knowing that most cancers will not develop on a genetic basis. And of course, for women-specific hormonal factors. Mainly the factors of estrogen for uterine cancer and the combined effect of estrogen and progesterone for breast cancer. And we'll talk a little bit more in detail when we get to the different cancers. So what can we do to find cancer? This is really the way to diagnose cancer, you know, find out about it early on. And breast cancer is really one of the disease sites where we are quite far ahead on that road, because many cancers are diagnosed very early. As a matter of fact, there's even a discussion that we diagnose lesions which probably would not cause problems for the patient's lifetime. It's just hard to figure out which lesions will and which lesion will not. So risk factors for breast cancer, especially hormone effect, usually estrogen and progesterone, because both hormones increase the growth of breast cells. Age more advanced age, meant in the after the change of life. Genetic factors play a role, especially mutations in the BRCA gene. This is a very large gene, so there are 2 of those genes which can be affected. And it's interesting that the gene product of these genes, so what they make, are tumor suppressors, meaning these genes code for proteins which control cell growth, which prevent abnormal cells from continuing to grow. And it's like taking a break of growth control. You know, then growth continues, and that way gives rise to malignancies. It's not only for breast cancer, it's also for ovarian cancer and to a lesser degree of other cancers. And then there are family history is important. Special findings at the breast, nodularities, a lot of fibrosis can increase the risk of breast cancer. And there are several, like the Gale model, which is like a scoring system. It takes into consideration the findings on breast exams, the age of the patient, hormonal factors, and so on, and family factors to calculate a risk profile. General prevention for breast cancer, again, normal weight. Physical activity also seems to reduce the risk of breast cancer, like with most other cancers. Now again, those are all very, very good things, and you'll hear me talk about those on multiple occasions. Now, even if you do all these things, it does not prevent you from getting cancer. You know, it still can happen, but it will ensure that you are ready to fight cancer much better. So it is important to focus on those things. It seems also that glucose control is important, and there is more and more data linking metformin, which is a drug we use for diabetes, the tablets we use for diabetes, may help in reducing the risk of cancer. There are many different growth factors, and then there is one insulin-dependent growth factor, which is then affected by this medication. And aspirin, again, put it here with a question mark. Again, aspirin is a drug which reduces cyclooxygenase. It reduces, again, an enzyme which affects several of those growth factors. You know, we are learning more and more about what makes a cell tick, and right now it's very, very complicated. There are so many different factors which interact. Looks almost like a street map of Houston or so. But I think the more we learn about it, the more we can focus then our prevention and our treatment, you know, in that direction. You've heard more about personalized medicine, that we are just not treating breast cancer, but we are treating a breast cancer with factors A, B, C, D. And I think in breast we have the most advantages of that research already coming into clinical practice. Looking at those growth profiles for high-risk patients, then one can do more about it. One can use hormone therapy. We know that anti-estrogens reduce the risk of breast cancer. So tamoxifen has been used to treat breast cancer, but it's also effective in reducing the development of breast cancer. Or the raloxifene, which is a drug we use to prevent osteoporosis, also reduces the risk of breast cancer. But of course, all those drugs have some side effects too, so they're not ready to be used in the general population, but they're worthwhile in patients at an increased risk factor. And for those with a BRCA mutation who are at a 70% risk of breast cancer, of course, a risk-reducing mastectomy with reconstruction is a good option. So consider that if you want to look like Angelina Jolie. which I'm thinking I'm very appreciative of her. You know, that someone looking like her, making her money out of looking very sexy and feminine, really lets everyone know she is fighting her increased risk of breast cancer by having a double mastectomy. It also should tell anyone you can have a double mastectomy and still look great. Screening for breast cancer. Self-examination is, of course, the easiest, always available, doesn't cost anything. It never has definitely shown to improve overall survival. However, many breast cancers are still diagnosed by the patients themselves, usually in patients who have their periods immediately after the period. Once the main hormone and progesterone effect is gone, that's the best way to do it. In the shower when your hands are all soapy. Also, watch your breast in the mirror by raising your arms up, taking them down slowly. Look for asymmetry, look for dimples. And I think that's an easy thing to get used to. It doesn't cost anything, it doesn't hurt, much less than a mammogram. And after a while, you know your personal lumps and bumps, and you can figure out what is new in even a much better way. Now, mammography, baseline around age 35. Now, that is for routine patients. And then yearly between 50 and 69, some even longer depending on the personal situation. There was a lot of discussion if it should be done yearly between 40 and 50. You probably listened to that in the press. Now, if you diagnose cancer early between 40 and 50, you save more years of life. But on the other hand, the diagnosis is not quite as accurate, so you have a lot of unnecessary biopsies and things like that. And important to tell all your friends, even if you don't have money, if you don't have insurance, you can try and get a mammogram at the health department. So not having money, not having insurance is no reason not to get cancer diagnosis. One other aspect about the family history thing is there are also special follow-up recommendation. You know, in patients with a family history, you may want to talk to your doctor about getting the mammogram, starting it earlier. And we also use specific MRIs, which are more accurate in the diagnosis of breast lesions. As far as treatment is concerned, we have learned a lot since the old days where mastectomy, removal of the breast was the only treatment. Mainly now there is a localized treatment, just taking out the lump with a normal margin, and then using radiation therapy and other treatments like hormone therapy, chemotherapy, in addition to that. And again, that is part of the individualized treatments. You know, for instance, someone who has a mutation in the BRCA gene and a cancer on one breast, they may be better off on having both breasts removed and a reconstruction. Also, if someone has a very small breast, it may just cosmetically look better if you have both breasts removed. But that is always a very individual decision. Okay, so next up is lung cancer. Now, everyone knows by now lung cancer and smoking. You know, don't need to discuss that. Even secondhand smoking may play a role. You know, rare in comparison, the occupational exposure, rarely radon, asbestos. Also some general medical problems and genetic factors. Now, we have not identified, like the BRCA gene, a typical lung cancer gene. We have identified, though, several genes which increase the susceptibility, so the chance that if you smoke, you will get lung cancer. So you know people who have smoked all their lives and are 95 years old and are doing just fine, whereas others have smoked only a few years and they get cancer. So again, there seems to be some genetic factors, mutation in certain genes, which increase the bad effect of smoking. But again, lots more research needs to be done. Prevention for lung cancer, it's stop smoking, also secondary smoking. So I think it's good that you're not allowed to smoke in restaurants anymore, or not only for the people visiting, but especially for the people working there, who are exposed to it 8 hours a day. Chemo prevention, a lot of studies have been done. We really don't have anything where we can give a definite recommendation. Now, in contrast to that, regarding screening, there has been a little bit of movement. A few years ago, a large study was done looking at low-dose CT scan to screen for lung cancer. Patients who have a long history of smoking, also even if they have stopped smoking for a while, were checked with a low-dose CT scan every year for like 3 years. And they found a 20% decrease in death rate. So earlier diagnosis related to screening, better localized treatment, better outcome. And of course, this is a very, very difficult thing to achieve. It's not only worthwhile to diagnose a cancer early, it also should impact the patient's life. So the chest X-ray as such is not effective. There are many things done looking at sputum. You could say, hey, if you can do a pap smear below, can't you do something similar for the top? But it doesn't work out as well. Although I'm hopeful that sooner or later we will be able to find something. There's some very interesting new research going on. Again, it's not for prime time yet. To look at DNA or RNA particles in the blood, which could be, abnormal particles like that, which could be secreted by a tumor. So there are also studies done in the past looking at entire cancer cells in the blood, because if a cancer spreads, it needs to oftentimes goes there through the bloodstream. So I think if these studies going to move on a little bit more, we may be able sooner or later, unfortunately I think later, find a blood test which would give us some more hints in this direction. As far as treatment, nothing really new. Initial surgery, oftentimes radiation therapy and chemotherapy. And sometimes these chemotherapies are quite aggressive and in early lesion improve survival. Next would be colon cancer. Again, you see the same kind of song. We're talking about obesity, and especially, the apple-shaped person, where is more central obesity. And that is not just the patient's fault. That is also a sign of a metabolic environment, a metabolic status, which increases the risk of colon cancer, which also increases the risk of heart disease and diabetes and all those other problems. Decreased physical activity, red meat. We know that especially if you grill a whole lot, you burn tissue basically, which also has some carcinogens similar to smoking, where you also kind of burn weed and inhale that. There are also several inherited factors. Polyposis are very important. These patients have hundreds and hundreds of polyps, and polyps are precancerous lesions. So they tend to get cancer early in life, so in their 20s and so on and so forth. And the other is the Lynch syndrome. And the Lynch syndrome, again, several genes are abnormal, which help in repair damage to the DNA. So again, the repair mechanism of the body is weakened. And that, of course, then allows abnormal cells to grow more and cancer to develop. Patients with Lynch syndrome are also at an increased risk of uterine cancer and a slightly increased risk of ovarian cancer. So we call that mismatch repair genes. Prevention, general cutting down on red meat, eating a lot of bran and fiber. I mean, you don't necessarily have to go down to the Stone Age diet or so, which is advocated, but I think staying with those factors is important, you know, and all those other good things. Now, there's also some data that aspirin and NSAIDs, so this would be Motrin, ibuprofen, and things like that, decrease the risk of colon cancer. And that, again, works through the cyclooxygenase. Again, this is an enzyme which is overexpressed in abnormal in cancerous tissue, but if you block it with medication, that may delay or just prevent cancer at once. Now, there is a lot of research done on that, mainly in patients at increased risk of cancer. We are not ready to recommend it for the general population because all those drugs have side effects too. You know, if you eat too much ibuprofen, you get a stomach upset, and you know, with aspirin, it can cause other sorts of problems. Now, another thing which seems to reduce the amount of colon cancer is curcumin. You know, that is part of turmeric and part of curry. So in certain areas in India where people eat a lot of curry, the risk of colon cancer is decreased. And it works very well. There are studies going on demonstrating the benefit. Just you have to eat a whole lot of it. I mean, in the gram-wise. So of course you can get tablets of curcumin. But still, there's a lot of research going on in this area, because if we could find, you know, something plant-like and so on and so forth, which would be good. The problem for other cancers, and which would be also blocked by curcumin, is that it is hard to absorb. So again, you need to eat a whole lot. Oops. For high-risk patients, sometimes even removing the colon before a cancer develops, and removing polyps. Now, removing polyps, that feeds into the screening test. If you have a colonoscopy, then any kind of polyps the doctor sees are going to be removed. And so it's not only the benefit of the test that cancer is diagnosed early, a benefit is also that cancer may be reduced completely because polyps and precancerous lesions are removed. So screening, usually you should celebrate your 50th birthday with a colonoscopy. Otherwise, a yearly blood test of the stool and sigmoidoscopy, just looking at the lower part of the colon, or colonoscopy every 10 years. Now, usually we do that, you know, with a scope, threading all the way through. There's also something now like virtual colonoscopy, which is an X-ray test. So a lot of other tests are possible or undergoing evaluation. As far as treatment, again, surgery is the initial approach of making an incision, or now more and more using a laparoscopy, where we just make little holes to kind of free up the tissue, or what we call hand-assisted, making a little bit of a bigger hole that at least we can get one hand in there to kind of do what needs to be done. But patients recover much faster from it. Now, sometimes even aggressive resections, even removal of liver metastasis, help with the overall survival of colon cancer. Again, goes to show that every cancer needs to be treated differently. We sometimes give radiation therapy and chemotherapy. Okay, gynecologic cancer. In the United States, uterine cancer is the most frequent. Ovarian cancer comes next. Cervix cancer is rare, only a little bit over 10,000 women a year, because we have screening. In the third world, cervix cancer is the most frequent gynecologic malignancy, because there are no screening. And this is what we're going to be talking about. This is the uterus, the uterine fundus. That's where the baby grows, and it has the endometrium, the lining. That's where the period is coming from, and the myometrium. That's the muscle around it. Then we're talking about the ovary, and more and more interesting now also in the fallopian tube, which up to now we thought was just kind of hanging there to get the egg to the sperm. And we're talking a little bit about the cervix, the mouth of the womb. There are two types of uterine cancer. The more frequent type, the type 1, which is usually diagnosed early and which is related to hormonal factors. And the type 2, which is not related to hormonal factors. Again, this is the cancer people get when they are slim and healthy and everything just fine. They still can get type 2 endometrial cancer. And those cancers are more aggressive. And rarely you can get a cancer from the wall of the uterus, like a sarcoma. And this is related to type 1, the most frequent endometrial cancer. There, the general theme is too much estrogen and too little progesterone. And that can happen in many different ways. Like you only take estrogen pills for hormone replacement. As a matter of fact, when we started using estrogen for hormone replacement after the change of life, the incidence, the number of patients with endometrial cancer went up. And what is going on? We figured out we need to give the progesterone, the second female hormone, which reduces the growth of the endometrium, the lining. And once we gave estrogen and progesterone for hormone replacement, the incidence of, or the number of patients with uterine endometrial cancer went down again. Again, obesity, it's estimated about 40% of those cancers are caused by obesity. And again here, it is not just eating more. It is more sophisticated in that these are factors which, number one, lead to obesity, among them insulin resistance, which also lead to differences in the steroid hormone pathway. So we're just starting to learn how much more complicated this is. And then also some genetic factors, the Lynch syndrome, we talked about that, and Cowden syndrome again, where is one of those translational factors is not produced adequately, and it increases the risk of cancer. Prevention, number one, regular cycle. You know, they always used to say you need to have a period every month to clean yourself. I thought, how stupid. But there is some truth to it. Patients who do not have regular cycle, and you don't need to do it every month, but at least every 3 to 4 months you should, because otherwise that's a sign that patients have continued estrogen but not progesterone, meaning they don't ovulate, they don't release an egg, they don't get the progesterone, so the lining of the uterus grows thicker and thicker, goes hyperplasia. And then there's a little abnormal cells. and then a few more abnormal cells, and then it's atypical hyperplasia. And then this continues until a cancer develops. So a period 4 times a year reduces the risk of endometrial cancer. Or you can just be pregnant all the time. You know, that is another way of doing it, because you have tons of progesterone. Or you can take birth control pills. You know, birth control pills usually have estrogen and progesterone. Or you can put the progesterone directly inside your uterus. You know, we have an IUD now with progesterone, the Mirena, which we even use to treat early endometrial cancer. And I think sometimes a hysterectomy for precursor lesions is important. As far as treatment, hysterectomy, removal of uterus, usually tubes and ovaries. And then there is this fierce debate now between the US physicians and the Europeans. We from the United States feel it's very important to remove the lymph nodes so we can tailor the radiation therapy. The Europeans feel that's completely stupid. We just give more radiation therapy. Overall, the outcome is the same. So there still needs to be one, you know, they do one study and we say this and this is wrong on the study. That's why you have that result, and they do the same with our studies. So the final word is still out, and it probably will be out for a few years to come. We use radiation therapy, sometimes just inside the vagina or sometimes also from the outside. For advanced cancers, we use more and more chemotherapy and a hormone therapy in selected cancers which are very sensitive to hormones. Next one, ovarian. That's always the most feared one, you know, the most deadly one. And because it is usually diagnosed late, in contrast to uterine cancer, which causes bleeding and is usually diagnosed early. If I would have my choice between a spread from the uterus to the omentum or from the ovary to the omentum, you know, this fatty tissue, I would take the ovary any time because it responds better to treatment than uterine cancer. So again, staging is what makes the big difference in overall survival. The problem with ovarian cancer is, number one, that we don't have 100% or even 99.9% accurate screening test, and that it is overall rare. You know, the average risk is 1.7%. So that means that you need to screen a tremendous number of people to find one type of cancer. And therefore, you have also a lot of false positives. So for instance, when we use the CA-125 level, this blood test initially, we did as many as 50 surgeries to find one cancer which was already advanced. So then screening is not worthwhile. Now, since we have learned more using different tests, combination of tests, following the development of tests, but still screening is not recommended for the general population. However, for patients at increased risk due to family history, it is strongly recommended. That's why when I was in medical school, I always thought family history, you know, so what do you need to do with that? But it is very, very important that you all know about your family history and know in as much detail as possible. I always say, if you keep a picture of Aunt Annie, keep the pathology report of Aunt Annie, because not all cancers have a genetic risk. So I think to keep track of that in the family, you know, who had a ovarian cancer, who had breast cancer, who had colon cancer, can be very, very important. Risk factors. We do not know the whole story for ovarian cancer. We think that ovulation plays a role, meaning when you ovulate, you know, the egg pops out of the ovary and causes an open area, and then abnormal cells can form, and that can develop into a cancer. We have learned now from those patients with the BRCA genes where we do prophylactic removal of the ovaries and tubes, meaning taking out the ovaries just to be on the safe side. And in a certain percentage, you find cancer in these patients, and they're usually in the fallopian tube. So now we think that probably a lot of the ovarian cancers don't really come from the ovary, but they come from the fallopian tube, because the epithelium, the lining of the fallopian tube, is a serous epithelium, and that's the most frequent cancer. And the theory right now is when you have an ovulation, the fallopian tube kind of lays over the ovary to pick up the egg, and then a few of the cells can get stuck in the ovary. And then when it heals, they get internalized, and they can give rise of a tumor. So we think the fallopian tube is really a very important factor. The other new thing which is coming down the pike is that we probably distinguish two types of ovarian cancer. The high-grade serous tumors, which come from the fallopian tube and have certain abnormalities in their growth characteristics, and the low-grade ovarian cancer, which are completely different, which have completely different growth characteristics. And if we talk about individualized medicine, in the future we hope we can get specific medication for the low-grade tumors versus the high-grade tumors. So inheritance, again, only about 10%. But in those patients, the risk is very high, up to 40–50%. So we usually recommend that those patients have frequent screening, and their screening is effective because they have a higher risk of cancer. And we also recommend that at age 30 to 40, they have their ovaries removed as a prophylaxis, because usually the risk of cancer, the incidence of cancer in these patients increases after age 40. Now, with the newer results, perhaps in very young ladies, we can just remove the fallopian tube and keep the ovaries in longer, because the ovary is a very important hormone producer, which is very important for general health. So prevention, know your family history, very important. And we're getting more and more generous with screening. Checking for family history. Probably now we recommend that almost everyone with ovarian cancer should be checked for a genetic mutation, especially someone from Ashkenazi Jewish origin, because there this mutation is very frequent. And it's usually best to check the patient with cancer. And I think the more information we get, then that would be important for her daughters and for her sons, which could be at increased risk. And because we have all those things we can do to reduce the risk, like frequent screening, breast MRI, pelvic ultrasound, mastectomy with reconstruction, removal of the fallopian tube. So this is something very important, because we have things which could reduce the risk of these high-risk patients. Again, birth control pills, reduce the number of ovulations. It's the same thing like with uterine cancer. Remain pregnant for 20 years or take birth control. Works the same way. And the birth control works for all patients. It also works on those patients who have a familial risk of ovarian cancer. It even works in the BRCA population. Of course, there you need to be careful, because the estrogen and progesterone, remember, increases the risk of breast cancer a little bit. Breastfeeding, removal of the tubes or removal of the uterus. It is a data that even if you have your tubes tied, that slightly decreases your risk of ovarian cancer. Now, although I don't have good data, I think instead of having your tubes tied, you may as well have them removed. Especially the distal part, the fimbriated part, that's where most of the cancers develop. And for high-risk patients, there are studies ongoing looking similar to breast cancer at some hormonal treatment which could reduce the risk of ovarian cancer. But I want to strongly convey that we do not recommend removing normal ovaries just for the prevention of ovarian cancer. Especially in young patients, the ovaries are important for cardiovascular health, for bone health, for sexual function. As a matter of fact, we're getting more and more conservative. There is no study so far proving that early removal of the ovary improves overall survival. If we look at all diseases, it may reduce the risk of ovarian cancer a little bit, but then it causes an increased risk of bone fractures and heart disease, so you haven't gained anything. So we are getting away from, I mean, when I grew up as a gynecologist, we said, oh, over age 45, we'll just take out the ovaries. You know, we are far from that right now. This is the indication for genetic testing. Again, first and second degree relatives. Any cancer at a young age. Remember I told you, cancer comes in different steps. So those with a genetic predisposition are already a step ahead. And that's why they get their cancer earlier in life. And we talked about this. Treatment, surgery. Very important, very aggressive to get all the abnormal tissue out, and that is usually followed by chemotherapy. And we are very, very slowly making progress. And we're starting to use some of those translational agents like the anti-vessel drug Avastin. You know, this was marketed in breast cancer. It seems also to be beneficial in ovarian cancer. But again, it's not the yellow of the egg yet. So it helps some, but it does not solve the problem. So last, cervix cancer. You know, again, most frequent in countries without screening programs. And even in the United States, most people presenting with a large cervix cancer haven't had a pap smear in the past 5 years or so. It's a perfect cancer for screening because it develops slowly. It has a long precancerous time. So there's plenty of time to get it detected and to prevent it. Risk factors. The main risk factor for cervix cancer is human papillomavirus infection. So whatever increases your risk of having a human papillomavirus infection also increases your risk of cervical cancer. Now, whenever you've been diagnosed of HPV, don't feel bad about it. You're joining about 80% plus of sexually active women. So this is a very, very common. So you're wondering if someone hasn't had it, maybe a nun, because otherwise it's so frequent. Now, at increased risk of are also patients who do not have pap smear. You know, there the precancerous lesions are not treated. And patients who have immune problems. It's not just getting the human papillomavirus infection. Most people get over it within a year or two. It's the persistence of the infection. And that is oftentimes influenced by the immune system. So patients who take a lot of steroids, patients after organ transplant, patients with HIV at a much higher risk. And smoking also increases the risk independently because some of the substances you inhale when you smoke come out of the mucus in the cervix and decrease the local immune defense. HPV infection, I don't think we have a lot of time to go into any details. There are over 100 types of HPV viruses. About 30 live in the genital tract, and there we distinguish high risk in types like 16, 18, which are mainly related to cancer, and other types like 611, which are more related to genital warts. And testing is available. And we're using this more and more now, even getting away from just the pap smear. For instance, for women after 40, you can do a pap smear and an HPV test. And if your HPV test is negative, you don't need another pap smear for 5+ years, you know, because that would put you at a very low risk. The screening recommendations have changed. We now start at age 21 because we know teenagers, they start sexual relations, they have HPV infection, they have slightly abnormal pap smears, and usually this goes away. So we start at age 21, check more frequently for women in their 20s because that's the main time where infections are received, and then follow every 3 to 5 years for people between 30 and 65. Now, usually after 65, if all smears have been normal and if the person has not been treated for any kind of abnormalities, then screening can be stopped. Now, not needing a pap smear every year does not mean you don't need a pelvic exam every year. So those are two completely different things. You do need, every woman needs to have a pelvic exam once a year. However, the pap smear does not need to be done every year. So that is important. Prevention, important now. The vaccination is out for the most frequent viruses. It's approved now for girls and boys. Although girls have the more problems related to it than boys, but the boys are the ones who distribute it, right? So if you want to get rid of an infection, you need to vaccinate the entire population. And usually this vaccination is tolerated quite well with minimal side effects. Sometimes it can hurt a little bit on the injection side or can give a mild fever. But I strongly would recommend it. Most insurance pay for it. And again, people who don't have insurance can go to the health department and get it for free. The best time is before sexual relations starts. So the young girls should be vaccinated. So that doesn't mean that they need to, then after that are allowed to screw around. So get them vaccinated before they even think of things like that. And then maybe sooner than you think. So the best time is around 11, 12. At that time, you also have the highest immune response. So far, we have documented protection for 10 plus years. Don't have any longer data because it hadn't been around any longer. Now, once cervix cancer is diagnosed, then surgery is usually the first treatment, sometimes even with preservation of the uterus, or sometimes we use radiation. Take-home message, very important, regular screening exams. Know your body. Even if you have had normal screening 2 months ago, if you have irregular bleeding through the vagina, discharge, rectal bleeding, lump in the bladder, you go back to your doctor. And if the exam then is negative, that does not mean you shouldn't have come. Don't feel bad about it, but sometimes it's important to check things out. Again, remember Aunt Annie's pathology report. And all this healthy stuff, probably all the other presenters talk to you about anyway. Warning signs. Any kind of unusual bleeding or discharge from the vagina or rectum. New onset of constant pain. A sore that doesn't heal. A lump. Change in bowel or bladder function. Persistent indigestion. We always say ovarian cancer. Indigestion, bloating, decreased appetite. Well, you know, we have one of these once a month at least. But the thing is, with ovarian cancer, you have it every day, and it gets worse every day. So, you know, kind of be in sync with your body. If something is different, then observe it for a while, but then you may want to check it out. And yeah, it's there, if you find out about it or not. So not seeing a doctor or not putting a name to it really does not make it go away, unfortunately. And these are some useful numbers. You probably can get a hold of those or using the website.